And welcome to ccclivecases.org. I'm Samir Mehta. I'm your moderator for today, and we have another very exciting and truly challenging case. This is session number 16 and session number 2 since we are being carried globally with the heart.org. Samin, good morning, and most of all, I want to welcome a wonderful addition to your team.
Yes, of course. We can get Roxana, you come this side. Now, as you see, that clearly we have started two new faculty with Roxana Mehran and Josh Dangus. Both have joined us as of September 1st. So we will be hearing that really a big addition to our the cath lab enterprise and add various skills, most important being the academics and the research. With that note, this case we start. This will be our case number 2 of the new presentation.
Samin, I want to chime in my introduction and welcome to Roxana. You could not have picked up a more talented person.
Absolutely, fully agree. Fully agree.
Good morning, Roxana, and welcome to the team.
Thank you. Thank you very much for all of this nice comments.
Now, this patient is an 89-year-old. That is actually the kind of patients we are getting nowadays. This patient presented on September 10th with a lateral and posterior wall STEMI for 8 hours. It was borderline hypotensive, little heart failure, was transferred to Sinai, had a balloon pump, assisted primary PCI of the circumflex. At that time, patient also has a left main disease, and of course, the medications point of view, which I have shown before presentation, patient was fine, did not go to too many doctors, and did not have any CAD risk score problems, and used to take only aspirin and metoprolol. Now, basically, if you see there, at that time, I'll go, the patient has a 3-vessel and left main disease with a syntax score of 28, had a 70% distal left main, along with the LAD and culprit being the thrombotic OM2, which underwent PCI, and I'll show you that data. And then, that time, we did a balloon pump, the patient did very well, few days later went home. Since then, patient continued to have class 2 exertional symptoms of angina and dyspnea on exertion, and follow-up echo done, still has moderate LV dysfunction around 40% and moderate MR. And today is the intervention, which will come back to this. This is the case when she presented on September 10th. You can see there is a distal left main, and we wired it with a run through, followed by, as because of the large amount of clot, this is the aspiration catheter and export catheter, followed by the stenting of that OM. Now, this patient, since presented at that time, acute situation, was placed, had a bare metal stent. Now, you see that left main is a significant left main, was left alone, and then patient was discharged home. Now patient comes back here, and we can go to our current cine, and Anu will describe.
Samin, during the first intervention, was there a problem advancing the pronto through the left main?
Yeah. Actually, there was no.
Anu, good morning.
Yeah, good morning. How are you? Just to tell you that when she presented at that time, we did not have any problem in actually wiring or advancing the pronto through the left main. I think if you see the picture, you will see there was a lot of thrombus burden, which actually got better with pronto, and then we did the direct stent of the circumflex. And today she's here. If you see her LV function, if the first, she has a EDP about 15, and actually the postero-basal wall is still dyskinetic, but the anterior wall and inferior wall is moving okay with the overall EF just in the 40 range. And this is a right coronary artery, proximal about 80%, not heavily calcified. And this would be her left system. Again, if you see this bare metal stent that we did looks still okay. Left main, distal left main about 80 to 90%, and this is her LAD. In the mid LAD, again not calcified, but a significant 80-90% lesion, and after in the distal LAD again moderate 50% disease. Two diagonals are there, a moderate size first diagonal. In the ostium, another 70-80% disease.
And that's a very important point, because people get very nervous about the passing your devices through the significant left main. I mean, we know that less than 50% is not an issue. But once you get to about 70 range like this patient, 70, 75, but I can tell you that many of these cases, unless patients are hemodynamically unstable, and that is where our ACC guidelines are, don't touch the non-culprit, and you can go through the left main with a little resistance. The key should be the resistance, the point you asked, that was there a resistance in terms of advancing your pronto catheter, aspiration catheter, or angiojet, or so and so forth, that if there is no resistance, it's easier to just advance and do the work and come out, and that's exactly Anu did about a month ago, went through it, used a pronto catheter, removed the thrombus, followed by direct stenting of the bare metal. Now the whole question about bare versus DES in acute MI, I'll keep it for some other part of the discussion, but the key is that we learned that yes, in acute MI setting you can use the DES based on the long-term horizons data up to 3 years now. Only problem with that remains is that you need to be sure patient will take dual antiplatelet therapy. This patient was our first exposure with the 89 years of age, and rightly so, we actually have put the bare metal stent in this particular case.
But I think there are several very interesting teaching points here about the fact that Dr. Kinney did the culprit lesion, and then the strategy of what to do with a patient with multivessel disease is something that she obviously thought about. And there was an STS score on this patient, a syntax score on this patient, and according to all of the guidelines, where there was a very good thinking about what should be the strategy of treating a patient like this with 3-vessel disease in whom the culprit vessel has been taken care of. And that's another reason why we should think about a bare stent, because suppose she's a good candidate for bypass surgery, then she can be referred to that. And I think if you look at that, there are several things that made you think about PCI in this 89-year-old lady. Do you want to talk about that, Dr. Sharma?
Good. Now, as you see, that our goal now would be that if we can go back to the slide, key would be that Anu will put a stent in the right coronary, and we'll come back to the left main, and we'll go through the points of today's, and those are the 4 important ones: LV support, the culprit versus full revascularization multi-vessel STEMI patients, and also the timing of CABG. If you decide for CABG,
right.
Then plaque modification and IVUS and unprotected left main stenting. And I'll just highlight, and as you saw, that the heart.org did a tremendously good job of putting the slides in the PowerPoint last month, so that anybody can download. Now clearly, when do we use assist devices? Basically, patients with the bad ejection fraction and complex anatomy, and that's very clear cut. You need to have a combination of 2. We also know that if it's a simple case, we can quickly go through, but it's the complexity, hemodynamic instability, and the LV dysfunction which determines who should get LV support.
Okay.
Supports are threefold: balloon pump, PTVA, and Impella. And of course, all are available at this time. They're all approved by FDA. And Impella is user-friendly so that it's more commonly used. And in really high-risk patients, those who are moderate risk, probably you can just do with the balloon pump. Now, this is a very simple algorithm which combines both ejection fraction and the lesion complexity. As you can see, EF more than 35, which in my opinion only mild LV dysfunction, you need balloon pump probably in the complex PCI. If ejection fraction is very low, less than 20%, patient hemodynamically unstable, those cases, in my opinion, simple or complex, should be done with the LV assist device, because our goal is to come out with the perfect results. We cannot lose the patient on the table, and these devices allow us to perform intervention safely, at ease, so that we do a better job as an interventionalist without any catastrophe. Now, in the middle ground, which is 20 to 35% ejection fraction, question is, should you use balloon pump? Should you use Impella or PTVA? I think one of the answer is very simple. If it's a simple PCI, probably balloon pump is good enough. If complex PCI, then the Impella or PTVA will be indicated, and this actually will be answered by ongoing trial Protect 2, which is randomizing these high-risk patients to Impella versus balloon pump. And of course, we'll know the answer. The trial is almost 2/3 done, and hopefully by next year, we'll have the data on the Protect 2 trial. Now, the second issue comes, the culprit versus full revascularization in multi-vessel disease STEMI patients and timing of CABG. Because there is a lot of data that if you have multi-vessel disease in the STEMI patient, should you do 1 vessel or you do all vessels, and the results are very mixed. Some says good, some says bad, but overall, in my opinion, the best would be the latest data which came from Hannon and ourselves from the New York State in the large number of patients, 4,000 patients. And these are few very important messages we learned from this. That if the patient is hemodynamically stable, that is our class guidelines are 1. Because if you are unstable hemodynamically, then you do every vessel. But if hemodynamically stable, you do a culprit vessel PCI versus multi-vessel revascularization at the time of primary PCI. And these are the 87% patients, despite the guidelines in New York State, got the culprit vessel PCI, but 13% got the multi-vessel PCI at the same time. So basically, as you can see, the blue bar, that basically if you did a multi-vessel revascularization in a hemodynamically stable patient, you have a higher in-hospital mortality. And the trend continues up to 42 months. So clearly, that it really enforces our guidelines again, that if you are hemodynamically stable, if your cardiac shock or hypotension is different, but hemodynamically stable patient, you should do only culprit vessel and leave the second vessel if you need to decide later on. Now, question is when you should do the second vessel. And this actually, again, very interesting data from our this paper, that is that you have 3 groups. These are all multi-vessel disease patients with a STEMI. One is the culprit vessel PCI only. Second group was you did a stage PCI, but during the same index hospital stay. We excluded the patient those 13% who had a PCI at the time 0. We don't want that because those are the bad, in my opinion, should not have been done. And then third group is you did a multi-vessel PCI, but it stays it out of the hospital in 60 days. The majority of them done after 30 days. So basically 3 groups. One, multi-vessel disease, but you did a culprit vessel PCI is the red bar. And if you did a stage PCI in the same hospital admission, you can see there that you decrease the statistically not significant, but trend towards lower mortality. But more important, that once you did stage PCI in 60 days, means after the hospital, let the patient recover like our case and 30 days and bring back. Look at the height of the green bar. In all the 3 categories, the best winner is that you do a stage PCI is 60 days on an average 30 days plus. The 1-year mortality was 1.3% versus you did culprit vessel only 5.5, and you did a stage multi-vessel PCI during the same hospital at the time of primary PCI was 3.9. And of course, that gradient continues. So the message is very clear that it's not a randomized trial, but clearly, and there is no randomized trial for this purpose, I can tell you, and will not be ever. You can just go by the registry data, and these are the case match control. That's why you have the similar number. The Dr. Hannon did a terrific job of combining, matching those cases, so that based on all the risk factors, that basically comes out to be that in multi-vessel STEMI patients should do a PCI and will translate into a lower mortality. And better strategy is that you do it as an outpatient in 1 to 2 months rather than at the same index hospital. I think financially this is a good also. Then second issue, like this particular case, if you have decided about cabbage, when do you do the cabbage? And we actually have the data of the New York State of the large number of patients of 7 days. This is actually beginning of 2000, that all patients, the mortality was 2.5, in no MI is 1.6. In MI patients is 3.1% mortality. Large number again, 44,000 patients who have history of MI and are cabbage in the New York State 3.1. Very important. The gradient, if you do a PCI, the cabbage within 6 hours to 1 day or more than 1 day. Clearly, it goes down after 1 day, become 2.8. It still remain higher than the no MI patients. So that now, if you go beyond, and this is basically based on the STEMI and non-STEMI, that when really you decrease the mortality, it seems to be 1 week. I know the original data used to be about 3 weeks, but I think in the modern day and age with the techniques of the bypass surgery, that 1 week, if you delay cabbage for 1 week is good enough. Of course, if you can do 2 to 3 weeks, you really go down to very low numbers, which is 2.5 and so. Preferably 2 to 3 weeks, but definitely 1 week. And also very interesting that in the New York State, whether you have STEMI or non-STEMI history, the mortality was 3.1% for both. So that basically stage the PCI 30 to 60 days, it stays the cabbage from 2 to 3 weeks after your primary PCI. Then question comes about the plaque modification, and these cases, remember the original Parks data, that in with a bare metal stent, plaque modification cases did better compared to no plaque modification, but those are the bare metal. Since then, we had done a lot of data in terms of DES, no randomized trial again, but I think in a calcific lesion, it makes sense to use a rotation atherectomy in some cases, just do a cutting balloon for the ostial lesions if there is not a calcific or angiosculpt. They both are good atherotomy devices, and they basically does cause the better expansion of the ostia of the distal left main or so in this particular case. So this we will decide based on the IVUS what device we need to use, or you could use a very high pressure balloon also. Then lastly issue remain, what about IVUS? And we'll ask Roxana to comment a little more on this issue, that there is just the registry data. As you know that there is no true trial in the IVUS and DES. The recent trial presented in TCT AVO by Colombo did not again favor IVUS guidance, that I think angiography guidance is good enough, except we have some data for the left main. And these are the from Park's data in the main compare. Although more patients got IVUS versus a small percentage got angiographic guidance, but you can see that there seems to be a lower death and lower MI rate if you do a IVUS guided left main. Now we have not completely changed our policy, but clearly their data are that if you do the IVUS guided left main, at least in left main, you have some suggestion that may be better. Then lastly, the left main stenting, we all know that it was a bad from the PCI point of view, DES, BMS, and then the DES, although the guideline until 2007, class 3, as early as last year, January, our appropriateness criteria, they put a left main isolated or with or without additional disease, with the diabetes or no diabetes, still made it as a I means inappropriate. So the left main until early last year was a problem. Of course, we have a lot of data with the bare metal. Overall, what we learned is that there is a death rate around 10% and restenosis rate of 22%, which in various left main DES trial, various results, but varying results, but largely because whether there was what was the percent of the distal left main bifurcation. But overall, what we did is we decreased the mortality and restenosis in half. What I say very clear, that the restenosis in left main may translate into mortality. So if you decrease restenosis, you will decrease the mortality in the left main patient. Always question comes, left main is 5.5 millimeter, what do I do? Do I put a bare metal or DES? There is one trial to answer that question from Australia. All patients had a cutting balloon and IVUS, and 50 patient balloon, bare metal, 50 as a paclitaxel eluting stent, and the lumen gain, acute gain was much higher with the BMS compared to DES, but you can see there that clearly higher restenosis with the BMS versus DES. Clearly, in my opinion, if you can left main, unless there is a contraindication of the dual antiplatelet therapy, should get the DES. And of course, now we have many trials and the registry data for the left main. The Limens is the one, the first one of the 100 patient trial, which compared the PCI versus cabbage. Although this trial has been highly criticized because the Lima use in this trial was in 66%. So but whatever the trial was, we had to just learn what is the message from the trial. Basically was that from MACE point of view, it favored PCI, but more importantly, the recovery of the ejection fraction, improvement in EF was higher in the PCI group versus cabbage. But the final answer was from our syntax trial, of which everybody knows, of the 700 patients, which basically gave the message same, cabbage and Texas DES, that if you have isolated or one vessel disease, which is the height of red versus blue bar, that the DES wins until the isolated disease. Once you get to a more complex 2 and 3 vessel, clearly the DES loses, and particularly it is a relationship with the complexity of the angiography, which is higher syntax score are the one they get more trouble, as you can see here with the DES compared to the cabbage. So clearly that high risk, higher syntax score patients will do worse with the DES compared to the bypass surgery. And this actually has continued. These are the 2-year data. More importantly, the data which was just presented in the TCT, I will share with you that 1 year, 2 year, and 3 year. You can see the Mackey rates. There is a non-significant trend towards favoring cabbage. Height of the red bar versus blue, that clearly non-significant trend. But more importantly, this message is, or this difference is accounted majority of the time by repeat revascularization. And this actually puts the latest data which was presented just a few weeks ago at TCT, the syntax score tercile and Mackey in the left main subgroup based on their risk score. Now look at the low risk score of 22 or less. Death, CVA, the favored PCI, lower event rate. MI although was still higher, but the two important points, so that basically that PCI still have a death, CV and MI lower, non-statistical again compared to the cabbage, and of course the revascularization was not different in the low syntax score. Second, if you go to the intermediate syntax score, the story still continues to be in favor of PCI, whether it's a death, CVA, MI of course non-significant as you can see, but you combine death, CV or MI, it still favors non-statistically the PCI compared to cabbage, and where we lose is clearly the syntax score of 33 and above. You see the double the mortality, 7 versus 13. CVA still higher in the cabbage group, but higher myocardial infarction, and therefore if you take those death, CV and MI, the hard endpoint which was favored PCI in the low risk groups, 22 to 32, that clearly now we started losing, and of course very high restenosis, 9% versus 28%. So that message basically is that high syntax score is a not with the left main, and usually that means these patients are the one who has a multivessel concomitant disease besides just the proximal and so, and should better be treated, should be referred for bypass surgery. And this comes back to the original point of our original point of the appropriateness. Then I think at least with the left main, our syntax trial, 1 year data was incorporated by the focused update guideline, which then made left main with a syntax score of 33 as a 2B indication. Clearly, that basically means less extensive 2B. And we know it has been a class 2A for patients with high surgical risk, that PCI can be done. Now, only one issue which I had basically is so that we need to have update on this appropriateness, in no question in my mind. If your syntax score is less than 33, new update on this guideline has to come. That should become U rather than I. The more important point, and a little disappointing, that in the article they do mention that the ostial left main isolated has a good outcome, as good as cabbage, but they did not go forward to make it a 2A or class 1. I think we should have been, and that is what European guideline did. That isolated ostial left main, they made it 2A. But clearly, I think this field will continue to evolve. The future updates may include it in an early category. And the final answer for this left main would be the trial which is being planned now, which is the Excel trial. And we will know soon once this gets off the ground, which will be a 2,500 patients. And very interestingly, the primary endpoints are different than what was the syntax was. It's similar to the freedom. Just like we learned from non-interventionalist Dr. Fuster, PI of the freedom, that revascularization cannot be the primary endpoint. It remains secondary endpoint. The primary endpoint remains similar to freedom, death, MI, and stroke at median of 3-year follow-up. And this basically puts it together, the overall presentation for today. And actually, the question always comes to the last slide, that what approach do you use for the left main? The majority of the patients is still in the trials have used single stent across. But to me, I think it depends if there is a large left main and there is a disease of the ostial of the circumflex also. The kissing stent has given a very good results. If it's the angulated vessel, probably the crush or T stent, more so for the small, because the distal left main is just like your distal aorta. That's where we started this our kissing stent technique for the peripheral or endovascular cases, so that there you put the 2 stents, they occupy the proximal part very well and have excellent results at our center. Now with that note, we come back to our team here with Anu, and can introduce our all our fellows with Vicky here, and Jab Bender and Usman Babar, and of course the rest of our group. Anu, tell me what you did so far.
Samin, also outstanding review of all the pertinent issue. Mainly, I am glad that you focused on the 2 really significant areas, the timing of surgery and how to deal with the non-culprit lesion. Anu, I am assuming you're going for the right coronary artery first?
Yeah, So if you see based on our diagnostic picture, see how this is a GR catheter and how the GR catheter is facing down. So you see that is a slightly upward takeoff of the right coronary artery.
Lima guide could also be another good option here.
Yeah, the question is same. Since she's, you know, the aorta is a small lady, we went with the no torque guide. You know, we get the, so that's the guide we selected. And if you see, we just pre-dilated and just did the stent. Now, as soon as we went up with the guide, we started seeing some dampening, and this is exactly how you do in this kind of situation, that if you have a dampening, that means there is some osteal disease. So you place the guide just outside the vessel, you wire it, you get your guide out of the vessel and do your, since this won't, we know that it would not require a lot of support, just with the wire and the guide outside the vessel, we were able to place the stent, pre-dilated, and put a 275 18 Zions. And once we gave a lot of nitro, if you see, the osteal lesion actually got better. So we just left that about moderate 30 to 50% osteal disease in the right coronary artery, and now we are with a guide, a 7th French guide, and the left system.
Anu, very well done. I'm glad that the right coronary artery is out of the way. It will help the patient get more perfusion. Samin, some people could argue, 89-year-old lady, you've already taken care of the culprit lesion. Why not leave her alone on medical management?
Well, I mean, I would say that except the left main, yes, because left main we know is a 15% mortality with the medical therapy. So that if a patient is functional, it will be a reasonable approach. If some other vessel, LED alone, I would go with that argument. But in this particular case, who has the otherwise viable, and we know significant left main. And then second issue is patient still remains symptomatic. Now that argument can still be made if you are asymptomatic. But clearly that even asymptomatic left main, unless you have written off the patient, I would that approach, in my opinion, will not be appropriate. And you can see all patient, the data which we showed you from the New York State included every patient. Now there is a no, we found out that the age, the young age are the patients who did better as a multivariate analysis clearly. That of course old age, because something will happen to those patients anyway. But the key remains is that those patients, irrespective of the age, are the one which was showed in the database. Now, Roxana, you are ready now?
Yeah,
That's your job now.
So we're going to look at the IVUS. The intravascular ultrasound is placed distal to the bare metal stent in the mid left circumflex. You could see the cross section, and here we come right into that bare metal stent. Can everybody see that? Can you please put the IVUS online? Perfect. So you can see the stent, and you see those struts of the stent, and the catheter is moving back. We could see the wire at about 10 o'clock, the intracoronary wire, and everything looks great. This was a very nicely well expanded stent right up against the vessel. It's a nice size vessel, at least 1, 2, 3 millimeter vessel. And here we come into the proximal circumflex, and you're coming in, and as you're going to see, you're going to come into the bifurcation. And we're going to see, here's the proximal circumflex, and here comes the bifurcation right into that distal left main, which looked to be severely diseased, and we're going to see that. And we're going to measure that, make that measurement. We know that in the intravascular ultrasound measure in the left main should be at least 6 millimeters squared with the area, the minimal luminal area. We know that that's sort of what we're looking for the best possible result.
But what is the criteria now? 5.5, 6? I know there has been a lot of...
Well, yeah, so there's been
consensus?
back and forth now, and about 6 millimeter was the original paper of Abizide and Mintz, and now there have been some consensus that perhaps that was way too conservative, and now we should really be thinking even in the 5.5.
Yeah.
Now, interestingly here, Anu is now wiring the LAD, and it's important to actually look at both. Angiographically, this looks like a 1-1-1. There is a distal left main. It looks like there's both osteal and osteal circ disease, but what we saw in the circumflex, when we came up on the circumflex, that actually it was just distal left main
Yeah,
ostial
the mid,
circ disease,
right?
and we're going
Just
to
the
make
distal
that
left main.
measurement. She's now moving into the LAD.
And we'll just concentrate. Get to the next one, please.
So let's go.
Wait. Let's do the measurement of the.
So are we going to measure? We're going to go back here, or we're going to make the measurements?
No.
Roxana, you want to comment on the
Pull back on the LAD, please.
No, we cannot. We have to do. Let's do
Oh,
the
we have
measurement
to.
here.
She wants to measure this.
No, but okay. Now show the IVUS the well.
Show us the
being
measure,
measurement,
so
yeah.
we can make the measurement. Dr. Kinney, can you move?
Okay, you just a little bit this side. Yeah.
Right, here she is. She's making a measurement now of the distal left main. And now you're going to make the circular measurements. If you show that, and you see that that is a steady hand. And here's our minimal lumen area, which is 4.55, so it's definitely significant.
Okay, go to the next
Now we're going to
one.
go and
We'll go to the LAD now. Yeah.
we're going to do the LAD run now.
Yeah.
Move back from the LAD. Let's move to that and do a.
Roxana, you want to comment on the level of calcification which you noticed?
Yeah, there was some calcification,
Nothing
but it
major.
was not circumferential. Most of this was a fibrotic, I would say a fibroatheroma there in that
Okay, you
distal
can.
left main.
Yeah, we are
Now
going
we're
back.
in the LAD.
Anu, you're going to interrogate the mid lesion also? or
Not the mid, just the left
distal
main.
left main, all right.
No, but wait a second. What is the issue here? Don't start yet.
There's some mid LAD disease
No, but
that
no,
runs
no, no, LAD will do.
intramyocardially.
But question is why the pictures are not good.
No, yeah,
Start
That's
now.
okay.
yeah, make a flush so we can
No,
see
you have to
that.
go forward. Little bit.
Okay, great. We have a very nice picture. Please go to the IVUS. Nice. Now we're in the mid LAD, and now we're coming in.
Okay. Bookmark
Osteal.
there.
That's the
That was the osteal. It actually didn't look so bad. You know, maybe we can make that measurement. It jumped a little bit because of
stop,
the
stop.
angulation, but I think you could still make that measurement. So, Dr. Sharma, angiographically it looks like a 111, but it may be a 101. You know, like the you might do okay with the.
Because LAD we still need to take care of the mid LAD.
Oh, okay.
Because there is a significant lesion in the mid LAD. I think once we start.
Okay.
The
So
question
then
is
better
that's a
not
very
to jail
important
that.
lesion.
Right
Yeah,
there.
yeah.
Right there. That's beautiful. So make that measurement there. Can you show that on the main screen for our viewers? The measurement of the IVUS. That's the
Yep.
distal,
Yep.
approximately distal
Why it
left
is not
main.
being shown on the
Can
screen?
you show the circular? Here you go.
good.
And what did you get for the
6.1 here.
6.1? So.
Just
so
about borderline in
interesting.
that area, yes.
So this now comes back to you, Dr. Sharma. It's your decision. Because you have an LAD lesion distally, you could, you know, this could be a single stent case if there was no disease in the LAD. And I think that's something that you want to have access to that LAD. You don't want to jail it. Certainly you're going to use both wires, right? 2-wire anyway.
Now
Yes.
you wire the circle.
Yeah. We have it there now.
So what are you thinking, Dr. Sharma?
Yeah, no, I think maybe, you know what, based on this I was finding, let's just take a quick picture in a different view of the osteal LAD. Remember
maybe an areocaudal.
yeah, there may be some kind of a caudal, either aleocaudal, because areo I think we had done at the
did an
time of your
areocaudal?
PCI also, that let's try to see, explore that. That's a very important issue. Put the
Yeah.
yeah, that bring the camera a little away. Bring. This one away. Yeah. Good. Let me just take
So, yeah, go to a very,
aleocaudal.
very deep angulated aleocaudal to show that osteal LAD. Can you move the lead from there so he can make his deep angulation? The skirt of the lead, yeah.
No, this is okay.
Okay, good.
Yeah, that's fine. Good.
You
Bring
see
it
it good? I think it's not LAO enough.
Yeah. Okay, good.
Okay.
Looks good. Yeah,
Yeah, there's a disease.
I think there's enough disease
Yep.
that.
I think we see it clearly, right? Yeah, it's a by definition our Medina 111, classical our Duke type D, which are the most common ones. And the key also that in these kind of cases, even if there is a mild disease, I would say, unless there is a no disease, that it probably should go. No, yeah, go to the LED now. Yeah, that these cases should be considered as to start with the two-stent technique, if that is the point. And you know that a lot of people are very much concerned about the two-stent approach, but we have been a very much proponent in all our papers, the review articles, and I have said that in about 25–30% of cases, which people say, well, I want to keep it pull back a little bit, that I want to keep it as a bailout as a strategy. To me, it's wrong. The key is that bailout strategy should be less than 5%. If you think you are going to use a two-stent, you will have a better result with a planned two-stent strategy, whatever your strategy is, compared to if you do a bailout, because you'll never get those perfect results in the bailout situation.
Can
Anu, that's
you walk us through what you're doing?
Yes. Now this is we just have a pre-dilatation again, 3O20 high pressure balloon, pre-dilated at
10 atmosphere.
10,
It actually opened up, and it was not a calcific, which we knew angiographically. A lot of people say, well, maybe by age it will be more calcium. I can tell you the angiogram, most of the time, the definition of the calcium in our lab, I mean, of course, everybody is different. Good.
and we have a 3O23. What do you want to do? 3O23?
Yeah.
Or you
There is
want
a
to
little
put-
distal disease also.
That you can
leave. Yeah, but I would
3O23.
leave that,
3O23.
right?
Yeah.
Yeah.
So, I mean, one of the other, I think, a true teaching point in this case is how is your approach different when you're dealing with complex patients in the truly elderly patients? And I've been wanting to ask what is the renal function and was there
her
any...
creatinine, if you see, her creatinine has been 1.1. Based, she still would be a CKD 2 to 3 because of her body weight. What a very important thing that we pay attention to this kind of patients when they come back or when we are doing first time is once you have the, we have a EDP and we know her EDP was between 14 to 15, we still are hydrating her on the table. She did get mucomist. She was in the hospital yesterday. She got mucomist yesterday and early this morning. And most important is that you see here we do our procedure with a very little time.
Any concomitant aortic stenosis in her?
Pullback, we probably saw that she had maybe a 10 millimeter gradient, though the echo did not.
Yeah, although she actually, they said moderate MR, but I can tell you that by looking at it, the way we had difficulty going in and pullback around 10 millimeter gradient, there was this will fit into a minimal aortic stenosis. Okay, this is the 3O, 23 Zions at 12 atmosphere. And as we put the question answers of the last month, that clearly that strategy at Mount Sinai, that angiographically pre-dilatation quite a bit, post-dilatation maybe in about 70%, but not in 100% of cases. The two inflation, the first inflation, you do a short, open the lesion, and the second one, try to leave it at 30 seconds, particularly these small struts, so that it's more a circular lumen, but small struts or thin struts, second generation DES take time to expand compared to the high, the thick struts of the first and second generation, which could expand very quickly, and we used to just go up and down. And here we do leave it for a few seconds to get a good results. Now, if you see angiographically some dent in the middle, or you had done the IVUS or in the stent boost, that is what we have, most of our labs are have the stent boost, that if you see a dent, then you bring back the high pressure balloon and do a dilatation there.
So how high did you go here in this case?
This is 12.
All right.
That clearly, as we have made it, the 12, more than 12 is contraindicated now. Many times you see a little bit of plaque shift proximally go. Little smoothing. I know a lot of people are concerned about it, but there is a mild plaque narrowing, and angiographically it will just take a little further. Yeah, just a couple of millimeter, just 2 atmosphere proximal, because vertical or downward displacement of plaque does take place in the large vessel, and there was some disease there to begin with. So that whether it is a dissection, of course the IVUS can tell, but angiographically, in my opinion, the basically just dependent on how it looks, and usually we smooth out, but here could be there is another lesion there proximally. You say that based on that? Anu, you want to comment on the previous angiogram?
Yeah, go back to
No, that's what we were thinking. Should it have been a 28? But then you see, you still have disease coming all the way proximal to the first septal.
Right.
Would not have covered with 28.
you
That's why I
need
said
one more.
23 would be okay.
Yeah, therefore, no, go previous
Go to
means
the
before the
original
stent.
lesion.
Yeah,
No,
before
no,
the
these are
stent.
before the stent to there. It's there all the time.
Yeah, because I think with the DES, it's better to err on the long lesion length, long stent compared to, because few millimeter you don't pay any penalty, which I would say you used to pay penalty with the bare metal, but not with the DES. Now, if required, I think I'll have a very low threshold of putting another stent proximally. All that's okay.
Would you almost then take it to the
No.
The point
just
is the
after the
28 will not
septal?
cover the left main. No,
Right.
I think it could be a good case, but the 28 alone still would not cover it. Now then question comes that what do we do for this our bifurcation strategy, and that's where we are coming down to now.
Roxana, how would you factor in 89-year-old patient with the syntax score?
Yeah, I mean, I think I'm sure that we measured the syntax score here, and the syntax score here
24.
with
Now
the
it is
left main is
24.
about 24.
It was 28 before, and now
Yeah.
after circumflex opening became 24.
Yeah, but it's really her STS score that really put her overboard with her age and her body weight and her, you know, some of the indices that you would look at as far as her surgical risk. But this is somebody who could be obviously referred for bypass surgery versus PCI based on the syntax study with that score. She goes right in the intermediate level. So one needs to discuss that and those options. And I think that for her and the patient's preference as well as you know, everything else in the setting of this acute coronary syndrome, the decision was made to move ahead with PCI, which I don't think is a wrong one. It certainly is something to be to consider.
And then particularly with the clinical syntax score, I think we need to start using a little bit more, because we knew that syntax score alone, by if you just talk about the angiogram, it's not going to tell you the long-term the mortality. It will do a lot in terms of the revascularization, but the clinical syntax score we have not started using routinely in our practice. I think you need to go a little bit.
Cutting balloon? Or
Yeah,
what?
this is
Okay.
a 356 millimeter cutting balloon
The question
with a
do we
flex
use
dome.
Yeah. So let's discuss that. What made you choose that and the length and all of that? Because I think these are important teaching points, Dr. Kinney.
Yeah, I mean, if you see here aorto-osteal as well as non-aorto-osteal lesion, it's not just the plaque. You also have some fibroelastic tissue there, and to get a good osteal result, especially if you are doing a bifurcation stent and osteal stent, to get a good expansion of the stent, you really have to go with a cutting balloon and do a good atherotomy.
Yeah. And now question is, this also happens that this short stent keeps slipping, although it's a good now,
Since it's a
3.5.
6 millimeter,
Yeah, it's
yeah.
a 6 millimeter. We do not carry the longer flex domes is only 6, and if you need to a bigger one, longer one, I would say the 10 millimeter we go with the angiosculpt. Now question is the data whether angiosculpt will be better in this situation versus a cutting balloon. I would say that our anecdotal that cutting balloon does a little better job in this cases, but instant restenosis or if you require high pressure, as you see that and what you did just now.
So what I did is actually took the cutting balloon in the guide and just went back in, which is actually going to rotate and change the blades. So at 3.5 you will have 4 blades. These blades will change and actually change your probably the cutting at the ostium. And we see that also this gives us another, it's another test to say that we have done a good atherotomy.
Look at that.
Well, you clearly have done a more than adequate, some plaque shifting into the ostium of the LAD.
Yeah, and that's a really good point to actually talk about, and that's another reason why when you have some disease in that osteal LAD and it's such a large vessel and you just put in a stent, this becomes a 2-stent strategy.
Now get us 2 trios, right? 28. What are 28?
So, Dr. Sharma, do you want to
Trio
tell us how
28
you,
and trio 15.
Yeah. Now, therefore, keep the same that you need to now. Many people will do a kissing balloon dilatation, high pressure. Well, that's nothing wrong in that. That's okay too. My only problem with the kissing balloon is that it may cause what happened? It may cause the dissections at the edges, and you may need to go a little further with the high pressure. And once you have this good devices, both flextome and angiosculp, that it gives you very good results without any causing significant dissection. So that keep it moderate. We do not go to high pressure. This is again 6 to 8 atmosphere. Trying to just do the ostial, the LED. Now, there is no true randomized trial to answer this question, that whether you can achieve the same results with the high pressure versus cutting balloon. But I know for the left main point of view, knowing that the majority of the left mains are distal left main, that expansion of the stents becomes quite important. And therefore, in these cases, I think you need to go 2 millimeters further? No. Okay. That in these cases, just like that Australian Argelis study showing that all cases they did with a cutting balloon and they did IVUS. And that, you want to take a picture? Okay. This is, no, take it out now.
So, I mean, in the meantime, it looks like the patient is tolerating the procedure well.
Right.
And also very important in this kind of situation where we know elderly lady has LV dysfunction and we are doing the left main, you have to be very important to make sure your blood pressure is in the double digits, and the way you are doing it, your inflation, deflation has to be very quick.
So, I mean, was there some consideration towards putting a balloon pump here?
Well, they actually, you know what, we thought about it, and the one decision otherwise were two factors which made us not to do it. One was EDP was reasonable, was not high. Blood pressure was good, 130/80. And secondly, ejection fraction by the echo is still about 40%. So with that note, I think you can put a balloon pump. In the past, we used to put a balloon pump. In many of these cases, go a little distal. Yeah. But nowadays, that the overall use of balloon pump, even in our left main intervention, is in single digits. So that you could do it, but more elderly patients, balloon pump is not without any complication, because biggest complication for balloon pump is vascular. But if it is required, you do it. And also, I can say very simple. A lot of people say, well, what if we put just a small sheath in? And so that I'm a little disagreement on that. Reason is that you decide based on your clinical judgment, based on your experience, that this patient will need balloon pump or not. And if you think that balloon pump will be needed, then you do it pre. You don't need to do it as a bailout situation. And actually, some of the study even from Washington Hospital Center showed that bailout versus elective balloon pump, you really get a benefit of the elective stenting, elective balloon pump rather than bailout. Now you see here, we have put a two
proceeding with the SKS strategy, and you want to tell us exactly where you want to have the proximal portion and how you're managing the carina.
No, I think you're okay. You just need to make a dot completely. This is a 3015 Promus is in the circumflex, and 3028 Zions is in the LED. Now same, that proximal point has to be dots, as you can see here very nicely. I just do a fluoro, and the both are aligned. Now clearly in the previous picture we have seen it, that they cover the lesion. You have to have coverage of the lesion that you are holding there. Good. Go both. We are going to go at 10 atmosphere. Simultaneous. Yeah, you can take the guide out if you need to.
That's your step number one.
Step number one, negative. Yeah. Then individually, now you see here, there is a little tough time. No, but this here, no, here. It's all here. Leave it, don't hold tight.
Blood pressure went down, but she's recovered nicely.
Yeah, therefore now you do individually, and Vicky will do keep negative. Vicky will do a great job of keeping the pressure. That now here, the LED at 12 atmosphere, 12 to 14 maximum, you could go. Now you go to the circumflex. Yeah. Yeah, 12, 14.
What about the LED down?
Yeah.
Down?
Yeah, that's down.
Good.
Good. We'll wait
More
few
negative
seconds.
on that LED.
Yeah. So basically what we need to do, just wait down to the fourth inflation, the each 10 atmosphere, give a neo bolus.
My blood pressure is recovering, but it's good to always be ready for it with neo.
Yeah. The key is that we tell everybody that neosynephrine comes in a 10 milligram per ml vial. You dilute you take it, of course, it's 1 ml, dilute in 10 and discard 9. The now remaining one you dilute again in 10. Now you have a 0.1 milligram or 100 microgram per ml and give it 2 to 3, and you can see just like this patient, blood pressure will go up by 20, 30 points intravenous and will cause slight reflex bradycardia, which is normal, and now you will be able to, things are stay set. We can go for the final inflation, initial 10 each, individually 14, and now we again 10, the fourth inflation of our technique, and now the pressure is nicely there, and now if the stent does not expand one or other, you can go a little higher, maybe different, 12, the LED 10 and 12, good, negative simultaneously, inflation and deflation. Yeah.
So I mean the distal part of the LED stent overlapped with the first stent you had put in?
Yeah, they actually, I see there is just maybe a 2 millimeter gap, but we didn't want to concentrate on that. See, this is again important point, that we don't want to miss the the distal left main for that purpose. If ever required, we'll put a one overlapping stent, no big deal. But there, our goal was to just have it proximally overlapped to cover the distal left main. So now, with your technique, you want to pull both of them, see how it should come out, both or one.
Also, you see that our guide was always outside when you have this situation. So, first thing you do, your guide is out. Make sure your distal wires you pull back so that when you're doing this technique, I'm trying to get more.
Anu, we are losing 1 second. We need to just adjust your mic. We've lost your. Samin, can you answer in the meantime as we adjust?
Good. Okay. Yeah, basically simple that now both the balloons have been withdrawn, and now pressure is very good. Now question comes is that what do you do? That do you take it out completely or you take a picture? I used to take it out, but Anu wants to keep both in the guiding catheter in the descending portion.
Yeah,
now
we have two balloons. If you see that show on the fluoro.
Yeah.
You have both the balloons in the descending. This is an 8 French guide, 7 French guide, and you still will be, you have your 2 wires, and you still will be able to take a picture.
And the key here is do not aspirate. If you have balloon there, you want to aspirate through your Y connector, you are going to get the air in the system. Do not aspirate, just go the forward and like here. Now, you want to take it out now?
No, same. I think if we are happy, take a cranial picture, then we can take out the wire and the balloon, entire system.
Well, I'd like to see.
And then we do IVUS. No, we definitely want to do IVUS, at least of the one of the vessel. No, definitely we should do IVUS. Yeah, you want to take these
absolutely. Out? That's a part of the final, and I think it's going to be a great picture just to show, because what you did is that your double barrel actually is very short in the left main. You really covered it just in the distal left main and didn't come too far back in. So we're going to see that very nicely on the IVUS as we come into the left main.
Okay, all the wires have come out, which happens. So just go to the LED. Let me take a picture now.
So, I mean, too quick.
Actually, now she has become hypertensive. That 200 microgram of the Neo we gave has made her put in the hypertensive crisis.
It might be just
and more blood flow also now. 1 second.
Yeah.
Take a picture.
Very nice. Yeah. And this actually, the IVUS will help us also to see what kind of a, we have a gap between the LAD and the left main stent.
And as you know, the plan basically, the Anu felt that let's just take out everything. That's the usual policy. But here, we have to rewire. We'll rewire and just do the IVUS. Because that is what, from our point of view, I just want to say to the people that from our, in our Mount Sinai cath lab, we are done based on that angiogram. Now we are doing it just for understanding. We need only one wire. That's okay. Yeah. That for understanding point of view, how things look, and do we incorporate and change our data based on what we are going to see on the IVUS is to be seen. But I can tell you that learning more about the IVUS, we have seen that of course you use the extra balloons, and there is a revascularization actually a little higher in the IVUS arm. I think part of that could be that you do a more dilatation, you have a little more distal dissection, whatever it is that. But in most of the IVUS trial, of randomized IVUS trials, that while the MI and maybe the mortality in the left main is slightly lower, but TVR is higher. And same thing in the AVO trial recently with the DES, that you just see that because of maybe edge dissection, whatever the regions are not clear, but insignificant trend towards higher revascularization. You want to go to
Yeah.
the middle?
So, I mean, a few quick questions which have come through. Anu can answer the first one. Bivalirudin or unfractionated heparin for this case?
We have a bivalirudin and our ACT, what's ACT, Vicky?
All cases.
Yeah.
The IVUS is buccal.
So, I mean, there is a question as to how has been your experience with the left main stenting for the very elderly, and how is your antiplatelet regimen?
Show us the
Has it changed in any way?
Yeah, no, but the same. I mean, those are the patients now coming to us.
Very nice.
So
for
this is
obvious-
the mid-LED stent.
Yeah,
Which
let's do the
looks
IVUS.
really, really good.
Nice expansion
Nice
and a good
expansion.
apposition.
Good.
Yeah.
So we're going to see there's going to be a small gap, I think, between that, but
Angiographically, there is a 2
it
millimeter gap.
angiographically looks really good, and this is important by IVUS to see.
Yeah.
And
See
it looks
there?
great. There it is, and really it's less than a
millimeter.
millimeter actually, about a millimeter. And that looks really nice, well opposed with your atmospheric pressure that you use. And we're going to come now close to the ostium. You see that
That's
coming in, not yet. It's a long stent. Here,
That's a double barrel.
it's not there. There it is.
There, yeah.
There you see it, and it was very nice. We saw the ostium.
Now you see the
that
double barrel.
lovely?
Yeah.
The double barrel. And you see it's a short double barrel, right nicely into the left main. Now, you're going to do the circ or not? Or are you done?
No, we are done.
Okay,
I think that's now.
good.
Yeah.
Pull back.
Just take a picture here.
IVUS. We show the double barrel of the IVUS.
Beautiful. So let's show you the run again.
Yeah.
Go show it. This is
Go back and,
Let me show one.
yeah, go ahead. Beautiful.
show that. Keep the
So
camera.
now you see the angiographic results are great, and now we're going to go back and show you the IVUS. Let's go to the IVUS. And right there is the double barrel.
Yeah.
Right there. Right there.
It's a very short, so that you just catch one
Yeah.
strut or 2 struts, right?
Yes.
Yeah,
So
and
you can see that.
it looks good. I mean, you could say, well, is that slit small, and you could measure that if you wanted, but I think it looks fine.
You wanted to measure.
Good. I think if it is okay, we can just come back to the last angiogram and the last slide, so that we finish. We started about 90 seconds late, but we finished it at 9 o'clock. With our team, or everybody from the cath lab team can come here, take the last slide of the take-home message, which is basically what we have spoken. That is that in this particular case with the left main PCI, that LV support and the lesion modification may be required in some complex left main PCI to carry out a PCI in a safe and effective manner. And that is the key, that you cannot have any catastrophe on the table. It's expected for us that patient comes in the cath table irrespective of their lesion and the clinical morphology, clinical scenario, they have to come out of the cath lab. Second, therefore you decide in patient with borderline, as we have shown, algorithm that in those cases you use a support device. Second, currently the midterm, now we know the 3-year data are favorable for DES of left main, especially with syntax score of less than 33. An Excel randomized trial will be the final answer. Lastly, the optimal technique and strategy are crucial to avoid any potential complication in complex left main PCI. Single stent crossover may suffice in majority, 65% of cases. But again, even in the syntax trial, majority of the patients have single stent strategy. But I can tell you, done all the cases and various complexity, angulated circumflexion. So once you have to put the bailout stenting or with conventional stenting approach, that now ostium is not well open, you put a second stent, it just becomes more troublesome, more difficult, and less than suboptimal angiographic result. With that note, I would say that we finished this fantastic case of this morning, and I'll let Anu to make the final comments.
Yeah, one important point while doing this case, especially left main elderly lady, if we are going to do it without a balloon pump or LV assist device cases, I think the point we made here is that have your blood pressure above the double digits. If not, give niacin, have your blood pressure high when you are doing your double stent technique, because no matter what, we saw that her pressure did go down when we are deploying the stents, and that's the time when most of the people get nervous. And if this is the kind of case you are doing it first time, second time in your practice, nothing wrong in having a balloon pump support on this particular patient. And since we have done this, we know how exactly to do these cases. But if there is any doubt, have the balloon pump ready, because the most important point is doing the left main. To come out with a good result, you need to have some kind of a support, and nothing wrong in have a balloon pump at that particular point. And the second point we wanted to make is that the same. We went ahead with doing a mid-RCA lesion, and we did see some osteal disease. Give plenty of nitro, get your guide out and re-evaluate the lesion. Most of the time it's usually moderate disease that can be left alone because she's an elderly lady, and we'll follow her up clinically. With that note, I think
I also think what you did was great in that you reduced very important complication in this lady, which is vascular complications from an intra-aortic balloon pump. So I think that was really great, and your pharmacology strategy was also to minimize bleeding in this lady, because these are the important complications, and you used Angiomax alone and things went very well.
Bivalirudin. Inhibition?
25%.
It's a Plavix is 20, platelet
PRU?
inhibition. In these cases, we always do. What is the PRU number? 270. That it's at the border. But at that age, I would definitely not change to FE, the Procedural, but definitely question is with this stent, maybe make it for 1 month. BID Plavix, and after 1 month go back to regular way. But with that note, I think I thank everybody, all our viewers, and Sami to you and my cath lab staff here, and of course Roxana and everyone to come and visit and keep giving us comments what we need to do. I already have a big request of the radial intervention. We will plan. We'll plan in few months that the radial case. The second issue has been the bifurcation. Those are the 2 requests we already have on our heart.org website, but we'll continue to take everyone's request and keep answering the questions, and any question anybody wants, we'll answer it within 24 to 72 hours of their posting on the website.
Samin, congratulations to your team, another outstanding case. I hope the viewers have learned some invaluable tricks how to manage a truly complex elderly patient. An excellent didactic review on the management of a non-culprit lesion with the STEMI, the timing of surgery. We'll be back November 16th for our next session, and as a final reminder, the entire case will be available for archiving soon. Thank you all, and we'll see you next time.
Do your thing.